the student help. In this video, we're going to be covering the antihypertensive drugs as our sixth video in the cardiovascular pharmacology. Now, as you know, that hypertension is a very common disease, and we can well control the blood pressure in all the patients with hypertension by using different categories of drugs. Now, let's get started with the etiology of the hypertension. Now, hypertension can arise as a primary disease, which means that it is basically starting on its own. It is not happening as a consequence of another disease. It is the primary disease. It is the primary problem. And in this case, it can be just a non-specific cause or as a combined genetic and environmental causes. Now, so this is so much into pathophysiology, I don't want to go in details, but let's mention a few secondary causes of the hypertension. Renal artery constriction, for example. As you know, if there wasn't a good perfusion of the kidneys, this means that there is not a good filtration of the plasma, and there is accumulation of the volume in the body, leading to hypertension as you expect. And the coarctation of the aorta, you know, when there is this congenital narrowing of the aorta, this can lead to hypertension as well. Pheochromocytoma, when we have this excess activation of the sympathetic nervous system due to a tumor in the adrenal medulla. And the Cushing's disease, the primary hyperaldosteronism, I'm sure you guys all know about such things, right? So all of these diseases would lead secondarily to hypertension, right? Now, when we talk about the antihypertensive drugs, we don't really care what was the cause of the hypertension, what was the main cause of it. We don't really care at all, because the treatment is going to be the same, except if we had like some surgical intervention that was needed to solve the problem. For example, renal artery constriction, so we can do something, right? And the coarctation of the aorta, so some of them like can be treated. So we treat the disease that has caused the hypertension, and then we deal with the hypertension. Now, regulation of the blood pressure. Now, we should really know, like, what does the blood pressure indicate? Now, from physiology, maybe you already know this, that the blood pressure is basically the cardiac output multiplied by the peripheral vascular resistance. Now, the cardiac output multiplied by peripheral vascular resistance. What is the peripheral vascular resistance? It is basically the TPR, or the total peripheral resistance. It's the same. And we know that most of the peripheral vascular resistance is created in the arterioles, right? So these very narrow ends of the arteries, the arterioles are responsible mainly for increasing the blood pressure. So when we are talking about decreasing the blood pressure by vasodilating the arteries, we would be mainly talking about the arterioles. Anyway, so in this figure, you see actually what is indicated behind the regulation of the blood pressure. So the resistance arterioles, so these are the vessels that are basically forming the peripheral vascular resistance. And we have the veins. We know that the veins are the capacitance vessels. So they are the storage rooms, as I have indicated in my previous videos as well. So if we do a venodilation, this means that most of the volume is going to be in the veins, and this is consequently going to decrease the volume present in the arteries and would decrease the blood pressure. And as you know that whenever we're talking about the blood pressure, we're referring to arteries, not to veins, right? So if we decrease the volume that is present in the arteries, this means that we're going to decrease the blood pressure. And how can we do that? By dilating the veins that are the storage rooms. Then it also depends on the pumping function of the heart. So if the patient has a failing heart, we don't expect a high blood pressure, right? Unless like he had another problem, for example, with the kidneys or whatever. But so you know that the pumping function of the heart is very important in the regulation of the blood pressure. So the other factor that is playing a very important role here will be the kidney. So the kidney is the main regulator of the volume, and the blood pressure mainly depends on the volume, you know. So the volume and the radius of the vessels. So if the radius of the vessels decreases due to vasoconstriction, we expect an increase in the blood pressure. And if the volume of the blood increased, we also expect an increase in the blood pressure, right? Now, you know if there was a problem in the renal artery, or there was a hypovolemia, or basically the perfusion of the kidney is decreased, we know that the renin system is going to be activated, and this is going to end up leading to the production of the angiotensin, and the angiotensin is going to increase the release of the aldosterone. Aldosterone is going to enhance the retention of the salts and water in the kidney, and the angiotensin is going to lead to vasoconstriction directly and indirectly on the vessels. If you don't know this already, you may check out our video on the RAS system pharmacology. Anyway, so let's actually get into the pharma part in this topic. So we said that there are a lot of categories as an antihypertensive drugs. So as you see here, we have 4 categories. The first is the diuretics, then the sympathoplegic agents. Sympathoplegic means that we are basically disturbing the sympathetic nervous system. We're trying to stop the sympathetic nervous system. And as you know, that the sympathetic nervous system actually, so the sympathetic nervous system is arising from the nuclei in the brain, right? And then we're gonna have a preganglionic neuron that is gonna go to the ganglion, and it is gonna basically like a crosstalk with like synapse with the post-ganglionic neuron, right? And the post-ganglionic neuron is going to reach into the receptors. So this is the path in the sympathetic nervous system. And when we talk about the sympathoplegic agents, we can stop the sympathetic nervous system either at this point, and this is going to be the centrally acting sympathoplegic drugs, or we can stop it at this point, and this is going to be the ganglionic blocking agents, or we can stop it at the adrenergic neuron blocking agent. We can inhibit these neurons from releasing neurotransmitters to the receptor, or adrenergic receptor antagonist, or we block this. So if you just remember this figure, you're going to remember these 4 subclasses. Okay, so either inhibiting on the central level, or at the ganglion level, or inhibiting the neurotransmitter release from the postganglionic neuron, or just blocking this receptor. Anyway, we're going to go in details later. Direct acting vasodilators is another way to help the hypertension, and we have different types. Calcium channel blockers, and here we would be mainly talking about the dihydropiridines, since we need to focus on the smooth muscles. We're not going to talk about the cardiac muscle regulation, since actually if we dilate the vessels by inhibiting the calcium channels in the smooth muscles, we're going to help the hypertension. We have other ways to help that. We're going to go in details later. And inhibition of the RAS system. I'm not going to explain this category. If you need to revise it, just check our video about the RAS pharmacology. Now, so let's get started with the first category, the diuretics. How can we use the diuretics to help hypertension? So let's actually think about it. We said that the blood pressure depends on 2 main things: the volume of the blood on one hand, and the diameter of the vessels, right? Now, the diuretics mainly, like clearly, it is going to decrease the volume of the blood. If we decrease the volume, we're going to decrease the blood pressure. Now, so the diuretics are going to deplete the body sodium stores too. We know that in my diuretics video, I've mentioned that most of the diuretics, in exception of, except the osmotic diuretics, they are all primarily salicylic and secondarily diuretic. And we say that salicylic means that they are getting rid of the salts primarily, and then they are going to get rid of the water, since the water is always following the salt, right? So the diuretics are going to deplete the body's sodium stores, and consequently we're going to decrease the volume. Now, I think you all know that, like, when you meet a relative or a friend who has hypertension, you're going to advise them not to eat salty foods, right? This is so common, like to just if a patient is experiencing a high blood pressure, we always advise them not to eat salty foods, because if we decrease the salt amount in their bodies, then we're going to decrease the volume, right? This is the same mechanism. So initially, diuretics reduce the blood pressure by reducing the blood volume, right? That's what we talked about. And the cardiac output. The PVR may increase as compensation mechanism. So this is the peripheral vascular resistance. Okay, now, so what we're talking about here is basically, now, you have given the patient diuretics, right? You have decreased the volume of the blood in his body, meaning that you have decreased the blood pressure a little bit. Now, the body is gonna find this, well, not normal, because it was experiencing a high blood pressure for a while, so it kind of got adapted to that. So when you decrease the volume and the blood pressure starts actually decreasing and approaching the normal value, the peripheral vessels and mainly the arterioles are going to constrict because they have been experiencing a high blood pressure, so it is like a reflex, right? And this is not going to be all the time. This is going to be at the first weeks of the treatment. So when you start treating a patient who has experienced a chronic hypertension, this is going to happen, that the peripheral vascular resistance is going to increase at the first couple of weeks of the treatment. But after 6 to 8 weeks, the cardiac output is going to normalize and the PVR is going to decrease. Now, when we speak about the cardiac output normalizing, okay, let's actually think about the cardiac output. How was it before we gave the diuretics? So, you know, like the cardiac output depends on the preload and the afterload, right? If you had like a very huge volume of the blood in your body, this means that the preload would be really high, and this may actually decrease the cardiac output at some point if the cardiac muscles were overstretched, right? And it also depends on the afterload, and we know that the afterload is the peripheral vascular resistance. It is how much pressure is facing the blood that is going out of the heart, right? Now, when you give the diuretics, you're going to help the cardiac output because you're going to decrease the preload and you're going to end up decreasing the afterload by decreasing the peripheral vascular resistance as well, right? So at the end, you're going to reach into a cardiac output normalizing, right? Now, the sodium is believed to contribute to vascular resistance by increasing vessel stiffness and neuroreactivity. This is an important sentence, okay, you should know. Well, it is not really clear like what is going on there, but it is maybe related that the increase, or let's say the decrease in the sodium concentration in the smooth muscle will end up decreasing the calcium concentration in the muscle too. And the calcium was responsible for stiffness, so if we decrease the calcium, we're going to decrease the smooth muscle, vascular smooth muscle stiffness too, right? So when you talk about diuretics, you're decreasing the volume and you're decreasing the salts, right? And you're decreasing the blood pressure. You may notice an increase in the PVR at the beginning. It is going to normalize after a couple of weeks. These are the important keywords. Now, it's a good treatment for mild and moderate hypertension. So the diuretics, well, they might be even enough in the mild hypertension because they can decrease the blood pressure by 5 to 10 millimeter mercury. Now, and the diuretics are always used in combination with the beta blockers, ACE inhibitors, angiotensin II antagonists. Of course, like either ACE inhibitor or angiotensin II antagonist, right? Now, in case of the acute hypertension, we would use the loop diuretics, like the furosemide, and in this case, we would give it IV in order to like reach the goal as soon as possible. In the chronic cases, on the other hand, we may use the thiazide diuretics and the potassium-sparing diuretics, either the aldosterone antagonist or the sodium channel blocker diuretics. Anyway, so that was all about the diuretic category. So let's go over it again. We said that we can use the diuretics to help the hypertension because we're going to decrease the salts in the body, and this is going to decrease the volume. If we decrease the volume, we're going to reduce the blood pressure. And by decreasing the blood pressure, and on the long term, we're going to decrease the PVR, the cardiac output is going to start normalizing at the end, right? And it is very good in case of the mild hypertension and decreases the blood pressure by 5 to 10 millimeter mercury. In the acute case, we use the loop diuretics and the chronic thiazide or potassium-sparing diuretics. Now, let's move to the second. The sympthoplegic agents. we said that sympathoplegic agents are the drugs that are gonna try to stop the sympathetic nervous system. Now, I don't know whether you know this, but there is the word, the so-called the sympathectomy. It is like the removal of the sympathetic nervous system. Now, we have pharmacological sympathectomy. It is pharmacological sympathectomy. So we're using drugs to stop the sympathetic nervous system. And in this case, like this is the case here, the sympathoplegic agents. So as I mentioned already, that in case of the sympathetic nervous system, we said that we have, we said that we have either inhibiting the sympathetic nervous system at the central level, or we're going to talk about the ganglionic blocking, or the adrenergic neuron blocking agents, or we're going to talk about the receptor blocking here, right? Now, so let's start with the first one. The first one is the central blocking, right? So we can just block the sympathetic nervous system at the central level, at the brain. So when you think about it, our drugs must be able to cross the blood-brain barrier in order to get into the central areas, right? In order to block it. Now, what do we have in the central areas that we can block? We have alpha-2 receptor in the central areas. Now, what do you know about the alpha-2 receptor? Let me remind you of this drawing. So you know that at the sympathetic neuron endings, we know that when the noradrenaline, for example, is released from the presynaptic vesicles, it is going to bind into this receptor. So as you notice that this receptor is present on the presynaptic membrane. It is an alpha-2 receptor, okay? Now, this alpha-2 receptor, okay, so this is our alpha-2 receptor, right? Now, alpha-2 receptor is very important because it is responsible for the negative feedback. When the noradrenaline binds to this receptor, this alpha-2 is going to start stopping the a further neurotransmitter release. It is a negative feedback. We have such an adrenergic receptor also in the central areas. So if we activate this alpha-2 receptor, notice it is not antagonism, it is agonism, right? If we activate this receptor, we're gonna create a negative feedback and we're gonna stop the sympathetic activation. Now, how can we do that? So as you read here, we have these drugs. They are listed in this category. Now, the prodrug in this case is going to be the alpha-methyldopa. I'm sure you've heard of it. And then we have the clonidine, the guanfacine, the guanabenz, the moxonidine, and the relminidine. Now, I'm going to explain each, how do they work. But before that, let me remind you, how do we produce the neurotransmitters in our body? And in this case, I'm talking about the noradrenaline. Now, as you remember, that in the sympathetic neurons at the nerve ending, we have here an active intake of the tyrosine. So as you see that it is taken along with sodium, which means it is a secondary active transporter, right? So this transporter is going to be uptaking the tyrosine, and the tyrosine is the precursor of the noradrenaline, right? Now, the tyrosine is going to be converted to the L-DOPA by the function of the tyrosine hydroxylase, okay? Now, then the L-DOPA is going to be converted by the aromatic amino acid decarboxylase into dopamine, okay? Now, forget about this name since it's very long. We can also call it the DOPA decarboxylase instead, sorry. So, tyrosine has formed the DOPA, right, by the tyrosine hydroxylase. Then the DOPA is going to form the dopamine by the DOPA decarboxylase, okay? Then the dopamine is going to be carried into the presynaptic vesicle. This is the presynaptic vesicle by the vascular monoamine transporter, right? Now, so the dopamine is going to come into this presynaptic vesicle, and then if there is an action potential running along the membrane of the neuron, there is going to be release of the noradrenaline. The noradrenaline has different fates. Okay, so it has like different pathways to go. So it can either activate the negative feedback, that is the alpha-2 that we have already mentioned, or it can act on these receptors that are going to be present in the postsynaptic membranes, right? Now, which of these will have the highest affinity to noradrenaline? If you don't know this already, but it is going to be the alpha 1 receptor. Okay, so the alpha 1 receptor has the highest affinity to noradrenaline. Okay, well, now, so the alpha methyldopa that we have mentioned here as a prodrug in this category that is going to inhibit the sympathetic nervous system at the central level, the first thing you already know about it, that it can cross the blood-brain barrier, right? Because it is going to act centrally. Now, the second thing, what is the mechanism of the alpha methyldopa? The alpha methyldopa is going to act as a false substrate of the dopa decarboxylase. What is the dopa decarboxylase? We said that the dopa decarboxylase here, okay, it was the one responsible for forming the dopamine from dopa. Now, if you give the patient alpha methyldopa, the alpha methyldopa is going to be carried to the neuron by active transport, and then it is going to act as a false substrate for the dopa decarboxylase, and it is going to lead to the formation of the alpha methyl noradrenaline at the end. Okay, so the alpha methyldopa is going to form the alpha methyl dopamine, and then the alpha methyl dopamine by the dopamine hydroxylase is going to form the alpha methyl noradrenaline. Well, you don't need to know like each step, how is it happening. You should know that the alpha methyldopa is a false substrate of the dopa decarboxylase. It's going to end up forming the alpha methyl noradrenaline, which is a false neurotransmitter. Now, where is this going to be? It is going to be inside the vesicle, right? Now, there was a sympathetic nerve activation. So inside the vesicle here, instead of the noradrenaline, we're going to have what? We're going to have the alpha methyl. We're going to have the alpha methyl noradrenaline. Now, what is the difference between the alpha methyl noradrenaline and the noradrenaline? Now, the alpha methyl noradrenaline has a very high affinity to alpha 2 receptor, to this receptor, which means that it is going to be activating what? It is going to be activating a negative feedback. When we activate the negative feedback, what is going to happen? There is going to be no further release of neurotransmitters, right? This is the mechanism of action of the alpha methyldopa. Now, so by acting on the alpha 2 receptor in the vasomotor center, this is going to reduce the tone of the vasoconstriction, right? Because we're going to stop the sympathetic activation, and the sympathetic activation was responsible for the vasoconstriction, so the vessels are going to relax, and this is an antihypertensive effect. Now, for what category of patients do we use the alpha methyldopa? This is a very, very, very important point, okay? Like, if you get this topic, you're definitely going to be asked about it. I personally was asked about it. So, whenever there is a pregnant woman who's hypertensive, we used to give the alpha methyldopa, okay? So, the alpha methyldopa, you know 3 things so far. The first one, that it is centrally acting, which means that it has the ability to cross the blood-brain barrier. The second thing, that it is gonna form a false substrate on this receptor and form the alpha methyl noradrenaline, which has a high affinity to the alpha 2 receptor, activating the negative feedback. And the third thing that you know already is that the main category of patients is the pregnant woman. Now, what are the side effects of the alpha methyldopa? Now think about it. We are stopping the sympathetic nervous system. What happens if you stop the sympathetic nervous system? The patient may notice or may experience some sedation, some depression, and some vertigo. Well, if you wanted to know only one, just know depression. Okay. Now, the next is going to be in the same category. We have the clonidine, the guanfacine, and the guanabenz. These 3 guys are actually derivatives of the alpha methyldopa. So they are not new drugs. They are derivative of the alpha methyldopa, which means that they will also act on the alpha 2 receptor and induce the negative feedback. But additionally, they are going to act on a receptor called imidazoline receptor. Okay? And remember, they are still agonists. We haven't mentioned any antagonists yet. We're still talking about agonism, right? So they are going to have an agonist effect on the imidazoline receptor. Now, what is the imidazoline receptor? It is a receptor that would be, for example, present here in the postsynaptic membrane, right? And this, it is going to be present in the presynaptic membrane, right? And it is going to also cause a negative feedback on the release of the neurotransmitters. So it is almost like that of the alpha-2 receptor, but it is not an adrenergic receptor. It is an imidazoline receptor, okay? Now, what is the effect? It is going to inhibit the noradrenaline release, right? Okay. Now, anyway, then we have two other drugs. These are the moxonidine and the rilmenidine. Now, the moxonidine and rilmenidine, unlike these three guys, they are not derivative of the alpha-methyldopa. Okay, so these are new. They are not derivative of the alpha-methyldopa, so they don't have any action on the alpha-2 receptor. They don't act here. They only act on the imidazoline receptor. So these are imidazoline derivative. They act on the imidazoline receptor as agonists, and they are going to inhibit the noradrenaline release. Okay, so let's go over this topic again. This category. Yeah, so we said that we're going to stop the sympathetic nervous system, and our first way to stop it is to stop it at the central level. At the central level, we have alpha-2 receptor, which is responsible for the negative feedback. Okay, we use the alpha-methyldopa. We said that it crosses the blood-brain barrier, it acts on the alpha-2 receptor, and it is used for pregnancy, and as a side effect, sedation and depression. Then we had the clonidine, the guanfacine, and the guanabenz, and we said that these three guys are derivatives of the alpha-methyldopa, so they basically act in the same way. As an addition, action that they are imidazoline receptor agonism. We said that this is a receptor that would be present in the presynaptic membrane, and it is going to inhibit noradrenaline release. And then we spoke about the moxonidine and the rilmenidine, and these guys are only imidazoline receptor agonists that are going to inhibit the noradrenaline release. Okay, let's jump to the second category. Now, the second is the ganglion blocking agent. So we said that to stop the sympathetic nervous system, we either stop it at the central level or the ganglion level. Now, the ganglion blocking agent. Now, before getting into details, when you think about the ganglion, what receptor do we have in the ganglions? It is the nicotinic, right? It is the nicotinic receptors, right? Now, so the nicotinic receptor, is it only in the sympathetic nervous system ganglions? No, it is also in the parasympathetic ganglions. So when you talk about this category, you should always keep in mind that we can't stop the ganglions of the sympathetic nervous system only, but we're gonna do both. We're gonna block the sympathetic and the parasympathetic. So do you think this is gonna be highly advantageous? Of course not. And that's why it is no longer available, right? It is no longer available clinically, and because of intolerance toxicities related to their primary actions. Okay, what is the mode of action? Competitive nicotinic receptor antagonist, non-depolarizing ganglion blockers. Now, I don't want to go in details in depolarizing and non-depolarizing, but yeah, if you don't know that, you should look into it because they might ask you. Now, what is the problem here with the ganglion blocking agent? That they may block both the sympathetic and the parasympathetic ganglion. What drugs do we have in this category? It is the trimethaphan. Now, the trimethaphan, when it blocks both, what side effects do we expect? Any side effect that you know as a consequence from blocking the sympathetic or the parasympathetic. What is most likely going to happen? Orthostatic hypotension, because you block the sympathetic nervous system. For example, sexual dysfunction. Guys are going to be sad about it. So this is a sympathoplegic side effect. Now, the parasympathoplegic side effects, if you stop the parasympathetic nervous system, the patient is going to also experience constipation, urinary retention, glaucoma, and a dry mouth. Anyway, so this was the second subgroup in the sympathoplegic drugs. Now, the third subgroup is the adrenergic neuron blocking agents. We said that we can either block it at the central or at the ganglion, or we can inhibit the neurotransmitter release from the post-ganglionic neurons, right? So in this case, we're going to inhibit or prevent the release of the noradrenaline from the post-ganglionic sympathetic neuron, and this translates to pharmacological sympathectomy, right? So pharmacological sympathectomy, stopping the sympathetic nervous system. What drugs do we have here? In this category, we're going to mention two drugs. The first drug is the Guanethidine, and the second drug is the Reserpine. Now let's start with the Guanethidine. You may already know the Guanethidine from Pharmacology 1, but if you don't, let me remind you that the Guanethidine action has two phases. Phase 1 is the so-called tyramine-like effect. What happens here? Now, so you know that, okay, maybe we can use this. So we can use it here. Now, you know that this NET, it was the so-called the uptake 1, right? Okay, it is hard to write it. It's not right. Okay, so we said that the NET here it would be like this. Okay. Now here, right here, we would have the NET. Okay. What was this NET? It was the uptake 1 mechanism. What is the uptake 1 mechanism? It was the receptor that allowed some release of the noradrenaline, okay, some leakage of the noradrenaline, right, on the expense of taking sodium. That was before applying the drug, okay, that was before applying the drug. Anyway, so you get it, right? You know it already, so it's just a reminder. Sorry, it's not the perfect drawing, but anyway, so you know that in the sympathetic nerve endings, there was an NET transporter present in the presynaptic membrane, and when the noradrenaline is released to the synaptic cleft, it will, okay, so it is released this way only when there is a action potential through the membrane, right? But the uptake 1 mechanism has allowed some leakage of the noradrenaline on the expense of taking some sodium. Now, how can we use this to apply the Guanethidine? Now, the Guanethidine is a smart drug. This drug is going to go in from this uptake 1 mechanism. Okay? And, oh, it's already here. So the noradrenaline used to just leave normally, right? Now, so our drug, the Guanethidine, is going to go in from this uptake 1 mechanism into the presynaptic cytoplasm, and then it is going to travel into the VMAT, right? From the VMAT to the presynaptic vesicle. Now, for each one Guanethidine molecule that is going into the neuron, there is going to be a noradrenaline leaking. Now, what do we mean when there is a noradrenaline leaking from here? This actually means that there is going to be a sympathetic effect. But what's like, how is this happening? We wanted to stop the sympathetic nervous system. How are we increasing the noradrenaline release? Yes, this is the phase 1 of action of the Guanethidine. It is going to be transported by the uptake 1 mechanism, meaning it will enhance the release of the noradrenaline. We don't want that at all, because it is going to increase the sympathetic nervous system. It is going to further increase the blood pressure during phase 1 of action, right? So it is an indirect sympathomimetic effect. It is a tyramine-like effect. But this is not the phase that we want. We want phase 2. So in phase 2, there is going to be enough Guanethidine accumulating inside the presynaptic vesicle that there is going to be no room at all for the noradrenaline, right? Which means that the noradrenaline is going to stay in the presynaptic membrane, in the presynaptic neuron cytoplasm, and if the noradrenaline is accumulating in the cytoplasm, it is going to be degraded by the by the MAO enzyme, the monoamine oxidase, something like that. I'm not sure. Maybe you should make sure of it. Anyway, so the MAO enzyme is the one that degrades the noradrenaline. Okay, so it basically breaks it down if it's staying in the cytoplasm. That's why we always needed to pack the noradrenaline into the presynaptic vesicles. So in phase 2, the presynaptic vesicle is going to be full of the guanethidine instead of the noradrenaline, and the noradrenaline is going to be broken down by the MAO, right? Now, so this is the phase 2 that is needed in case of the guanethidine. So it will be concentrated in the presynaptic vesicle, leaving all noradrenaline in the cytoplasm that will be degraded by MAO. So Reserpine-like effect. You know, what did Reserpine used to do? This is our second drug. Reserpine is a blocker of the VMAT. It is a blocker of the vesicular monoamine transporter. Okay? If you block this transporter, this means that the noradrenaline is going to stay in the cytoplasm. And we said that the cytoplasm is not a safe room for the noradrenaline, since the MAO enzyme that is present on the on the outside membrane of the mitochondria, it is going to degrade the noradrenalines. That's why if you block the VMAT by Reserpine, the noradrenaline is going to be broken down. So the second phase of the guanethidine, it mimics the Reserpine function, because the noradrenaline is going to also be accumulating outside, being degraded by the MAO. Okay? Now, what are the side effects of using the guanethidine? There is going to be a postural hypotension. So if they stand up, they may feel dizzy, sympathoplegic, diarrhea due to the parasympathetic predominance, since you're basically stopping the sympathetic nervous system. Do we use the guanethidine? Well, no, not really, not used anymore. Okay. Now, the Reserpine, as I mentioned, that it is an inhibitor of the VMAT. What you should really know that it is an irreversible inhibition. This is very important, right? Because you know that if any drug is acting irreversibly, this means that the body has to produce new receptors to restart the function, right? Now, and the Reserpine is not specific. It blocks both 1 and 2 VMAT receptors that are present in the noradrenergic neurons, in the dopaminergic neurons, which means that there is going to be also decrease in the dopamine release. And what does this translate into? You always know that the dopamine is related to pleasure, right? So as a side effect, in case of the Reserpine, the patient is going to go into mental depression, and that's why we don't use it anymore. So we don't want to help the hypertension, and then the patient is going to get depressed and may commit suicide, right? We don't want to use the Reserpine. Okay, so this was our third category in the sympathoplegic drugs. Let's go to the fourth one. It is the adrenergic receptor antagonist. So if we didn't stop the drug, if we didn't stop the sympathetic nervous system at the central level, neither at the ganglion level, neither we stop the noradrenaline release, we can just block the receptor, right? So this is going to be very important, since it is very commonly used. Now, the receptors that can be blocked are the alpha-1 and alpha-2 together by a drug called the phentolamine. So the phentolamine is not selective. It can't differentiate between alpha-1 or alpha-2. It's going to block them both, and it is reversible. It's fine. It doesn't covalently bind to these receptors. Now, when it blocks the alpha-1, this is going to lead to vasodilation, and it is going to lead to reflex tachycardia. Why? Because the blood pressure is going to suddenly drop, because you dilated the vessels. Now, when it blocks the alpha-2 receptor, it may lead to stimulate the noradrenaline release. Why? We said that the alpha-2 is responsible for the negative feedback. What happens if you remove the negative feedback? The release is going to be enhanced, right? So if we use an antagonist to the alpha-2 receptor, this is going to release the noradrenaline, which we don't want to happen, right? So this is going to be a side effect, because it is going to lead to tachycardia, right? So if we release the noradrenaline due to the alpha-2 blocking, it can lead to tachycardia. This is the side effect of the phentolamine, in addition to postural hypotension that can develop due to the vasodilation. Now notice that the tachycardia here is not only because of the release of the noradrenaline due to the blockage of the alpha-2 receptor, but it is also a reflex tachycardia due to the postural hypotension. Okay, the second drug here is going to be the phenoxybenzamine. Now, phenoxybenzamine, on the other hand, it covalently binds both alpha 1 and alpha 2 receptor, meaning it is irreversible. So when do we regain the function of the alpha 1 and alpha 2 receptor? When we produce new receptors. We can't use the ones that have been blocked by that drug anymore. Now, when can we use the phenoxybenzamine? In what diseases? We can use it in the pheochromocytoma. This is like a very important thing to mention in your oral exam, that the phenoxybenzamine is used in the pheochromocytoma. And it has a long half-life because it is irreversibly covalently binding. Now, the second category is going to be the selective alpha 1b blockers. Now, you know that the alpha 1b is the receptor responsible for the sympathetic action on the smooth muscles that are present in the vessels, mainly where in the arterioles. Okay. Now, if we block this receptor, we're gonna inhibit the vasoconstriction. These drugs are very commonly used. So the Prazosin Doxazosin Terazosin. Now, Prazosin, comparing to these two guys, it has shorter half-life. It has a very short half-life, and it has a very high first pass, meaning that we need, sorry, here should be a space. Anyway, a high first pass means that we need a high oral dose. Now, what is the side effect of all of these three? Of course, there is going to be postural hypertension because you're dilating the vessels, sudden drop in the blood pressure, and a reflex tachycardia. Now, on the other hand, doxazosin and terazosin, the only thing that you should know is that it functions for a longer time. Next is the non-selective beta blockers. So it blocks beta 1, it blocks beta 2, it may block beta 3. This is the propranolol. Propranolol acts on both beta 1 and beta 2. This is, of course, disadvantages. Always being non-selective is disadvantages. The inhibition of beta 1 is useful to reduce the work on the heart, right? The work of heart, the work of heart, this should be a space here. Anyway, inhibition of beta 2 is not useful. Now, so let's get back to this. If we block beta 1, right? If we block beta 1, we're going to decrease the heart function. We're going to decrease the contractility, the ionotropicity of the heart. And if we decrease the pumping function of the heart, of course, the blood pressure is going to drop because the pumping function is highly responsible for the blood pressure too. Now, inhibition of the beta 2, on the other hand, is not going to be advantageous because the beta 2 is also present in the bronchi, right? And it is going to lead to hypoglycemia. So it blocks the gluconeogenesis by beta 2 receptor, leading to a hypoglycemia. Okay? Now, they also have a remarkable first pass, and they need a high dose of the drug is going to be needed. Now, next category is the partial agonist of the beta receptor with intrinsic sympathomimetic activity. Now, in this case, we're talking about agonist. Notice, this is important, okay? Because it would be like horrible if you said partial antagonist, right? Because there is no partial antagonist. There is partial agonist of the beta receptor. When do we use a partial agonist and why? We use the partial agonist in case of the elderly people, okay? We use the partial agonist in case of the elderly people. Why? Because it is going to lead to a mild negative heart effect. We don't want to depress the function of the heart extensively because their hearts aren't that strong anyway, right? So in the elderly people, they wouldn't tolerate using a beta 1 blocker sometimes, so we may use a partial agonist of the beta receptor. This is going to be like the oxyprenolol, the pendolol, the acebutolol, and the penbutolol. Okay? Now, next category is going to be the cardioselective beta receptor blocker. So, cardioselective is the beta 1. So, beta 1 selective blockers. As you know, these guys are the metoprolol, atenolol, betaxolol, bisoprolol, nebivolol, and ceriprolol. Now, if we block the beta 1, again, we're going to decrease the function of the heart, right? We're going to decrease the cardiac output, we're going to decrease the renin release, the noradrenaline release, and the baroreceptor function. Now, the thing is, that the beta blockers, well, they are never used alone or almost never used alone. So we always combine them, like either with diuretics and such things, right? Now, with the other categories. Now, next is something weird, which is a drug blocking alpha and beta receptor together. This is the so-called the labetalol. So labetalol would be used in case of the pheochromocytoma and in case of the hypertensive crisis. You should know this. So I don't know like what more to say here, but the pheochromocytoma and hypertensive crisis, we can use the labetalol. The urabidil, on the other hand, it is also an alpha and beta receptor blocker, but also it is a serotonin agonist for the receptor 5 serotonin 1A. Okay, it blocks the alpha 1 and 2 and beta 1. So not only just alpha and beta, alpha 1 and 2 and beta 1, and it is a serotonin agonist. We can use these as a blockers of the adrenergic receptors to stop the sympathetic nervous system. Now, let's go to the third category, which is the direct acting vasodilators. Just let me show you where are we right now so you don't get confused. We've already covered the diuretics. We've talked about the sympthoplegic agents, centrally acting, ganglionic blocking, adrenergic neuron blocking, adrenergic receptor antagonist, right? So we are here right now, the direct acting vasodilators. Now, so we say that the vasoconstriction of the vessel, it plays a very important role in the hypertension. If we solve this problem and we dilate the vessels, then we're going to help the blood pressure. How can we do that? We can use the calcium channel blockers, the dihydropiridines, as I already explained in my first video. The calcium channel blockers, you can check it out if you haven't already watched it. And I mentioned there, like for example, about the Nifedipine. If you use the Nifedipine or whatever dihydropiridine, the patient may also notice a reflex tachycardia. He may experience dizziness and peripheral edema. Now, I'm not going to go in details and like waste much of your time. So just check it out if you haven't already. Now, the second one is the one that you maybe haven't met yet. This is the potassium channel. Well, it is not really. Okay, this is the potassium channel. Not blockers, really. It is not blockers. Okay. These are potassium channel activators. Okay. Now, the potassium channel activators are basically drugs. Okay, let me write this here so you don't get confused. Now, activators. Okay. Now, activators. Right. Now, so the potassium channel activators, they are drugs that are going to open the potassium channel. Now, okay, let's get focused here. You know that in the cell, just like in almost every cell, but let's take the cardiac muscle for example. You know that during the depolarization, you know, like when we used to talk about such things in physiology, we know that here would be, for example, a sodium influx, right? Sodium influx into the cell, which means that the sodium is going to be coming inside the cell. And then if we want to do a repolarization, then the potassium is going to go out, right? The potassium is going to get out of the cell in order to do a depolarization, right? Now, okay, so if we open the potassium channels, this means that the positive charges that were inside the cell are going to leave. If they leave, this is going to lead to hyperpolarization. And as you know, that the cell is functioning, or the muscle is functioning when it is depolarized. And if it is hyperpolarized, it is relaxing. So this is the mechanism here. We basically just take the potassiums outside of the cell, and this is going to lead to hyperpolarization, relaxing the muscle. In this case, we have the minoxidil. This is a very important drug because the minoxidil, if the patient takes the minoxidil, is going to experience hypertrichosis. What is the hypertrichosis? The hair is going to start growing everywhere. So it's going to notice like growing beard, growing hair, like facial hair, hair on the back, and like random places that he didn't notice. And actually, the minoxidil can be used as creams. Like, I don't know if you guys watch TV that much, but in these creams that like they put on their head in order to grow their hair, or in the beard, for example, it also contains minoxidil. Anyway, so this is not, not our topic, but anyway, so the minoxidil can lead to hypertrichosis, and it can lead to fluid and salt retention due to the RAS activation. Why? So because you have basically, you relaxed the smooth muscles that are present in the vessels. This has led to what? This has led to vasodilation. Vasodilation means that the blood pressure has dropped. This means that the perfusion of the kidney is what? Is decreased. And this is going to lead to RAS activation. RAS activation is going to lead to fluid and salt retention again. This is a side effect. And also the drop in the blood pressure can lead to baroreflex activation, which means a reflex tachycardia. Okay? Very simple. Now, the second drug in this category is the diazoxide. Now, diazoxide also opening the potassium channel, leading to hyperpolarization and relaxing the muscle. But the thing about the diazoxide, that it mainly acts on the arteriole. So this is advantageous because it is going to reach the target that is causing us a problem very fast, right? It is going to reach it as soon as possible. And that's why we can use it as an IV drug in emergency, and it is going to function in 3 to 5 minutes. So if a patient represents in the emergency and he has a very high blood pressure, we may give diazoxide and decrease the blood pressure within 3 to 5 minutes. Now, what is the side effect here? Is a hyperglycemia. Let's discuss this. How can a hyperglycemia develop if you're using diazoxide? Now, are the potassium channels present only in the smooth muscles of the vessels? Of course not. They are present everywhere. And one of the cells that has a potassium channel is going to be the beta cells that are present in the pancreas. So the beta cells were responsible for the release of insulin. Now, what happens if you open the potassium channels in the beta cells that are present in the pancreas that were responsible for the release of the insulin? There is going to be hyperpolarization. If there was hyperpolarization of these cells, they are going to no longer release insulin, which means that the glucose is going to accumulate in your blood, leading to hyperglycemia. As simple as this. Okay? Now, moving to the third one here. So the third drug that is going to act directly as a vasodilator is a drug that is going to increase the cyclic nucleotide concentration. Now, in this case, when you think about the smooth muscles, now, the smooth muscles, they love the cyclic GMP, because the cyclic GMP, if the intracellular cyclic GMP increases, this is going to lead to smooth muscle relaxation. Okay? Now, what can we do in this case? We can use a drug called the sodium nitroprusside or nitroprusside, I don't know exactly. So sodium nitroprusside, let's say. This drug, it actually contains cyanide. Now, this cyanide, well, it's toxic, right? So when you give the drug to the patient must be able to metabolize the cyanide. Otherwise, the drug is going to be toxic. Now, how do we metabolize the cyanide? We usually just combine it with other stuff to decrease its toxicity, okay? So it is metabolized by liberation of the cyanide, toxic in this form, so it must be converted to thiocyanate. So it is combined to something else in order to decrease its toxicity, and then we get rid of it in the urine. Now, if the patient is defective in the cyanide metabolism, so defective cyanide metabolizer, this is going to lead to intoxication. Now, how can we help this patient? We must give them some drugs or some agents that are going to bind the cyanide and decrease its toxicity. In this case, we can give the sodium thiosulfate as a sulfur donor, or the hydroxycobalamin. You know what is the hydroxycobalamin? It is vitamin B12, right? So you can give the hydroxycobalamin or the sodium thiosulfate in order to bind this cyanide and to decrease its toxicity, this toxic compounds with cyanide. Now, let's get back to the mechanism of action of the sodium nitroprusside. So, the sodium nitroprusside is going to act by enhancing the noradrenaline release on one hand, and it is going to act directly on the guanylyl cyclase enzyme. Now, what is the guanylyl cyclase? You know that the guanylyl cyclase is the enzyme that used to convert the GTP into the cyclic GMP, okay? And there is guanylyl cyclase present in the membrane of the cell, and there is guanylyl cyclase present in the cytoplasm. So when you give the sodium nitroprusside, it is going to increase the NO, and the NO is going to act on the cytoplasmic guanylyl cyclase and increase the cyclic GMP. Or the sodium nitroprusside itself is going to act on the guanylyl cyclase and increase the intracellular cyclic GMP. Now, what happens if you increase the intracellular cyclic GMP? Relaxation of the smooth muscle. So there is going to be vasodilation. When there is vasodilation, we're going to decrease the blood pressure. So the other thing that is important about this sodium nitroprusside, it doesn't like light. If it faces light, if it was exposed to light, it is going to become toxic. So that's why we have to cover the bottle with foil, right? And the sodium nitroprusside is used for the hypertension crisis. Now, our last one in this category, in the direct vasodilators, it is unknown mechanism. We don't really know how does it function, but it is a good drug. Now, the hydralazine, which is actually not used anymore, I think, but anyway, so it has an unknown mechanism. We don't know how does it vasodilate, but we know that it was the first drug that could be given orally. Okay, it is an antihypertensive drug that was given orally, and it acts mainly on the arterioles. It is always used in combination with diuretics and adrenergic blockers due to the compensatory mechanisms. Okay, because like if it actually forms a reflex tachycardia, we can stop this reflex tachycardia by using beta blocker, right? And if it caused RAS activation, we can inhibit the RAS activation either by the ACE inhibitors, or we can use diuretics and just reverse the function. Okay? Now, it was used in the acute cases, but it had a very serious side effects. These are the drug-induced SLE and the vasculitis and the glomerulonephritis. On the other hand, some minor side effects like headache, nausea, hypotension, and tachycardia. So this was the direct acting vasodilators. Again, we talked about the calcium channel blockers, dihydropyridines, and then the potassium channel activators, okay, the minoxidil, the hair growing drug, and the diazoxide, the emergency IV, right, that causes hyperglycemia by inhibiting the insulin release. And then we talked about the increasing the cyclic nucleotide concentration, which is the cyclic GMP. And we said that the cyclic GMP is going to cause relaxation of the smooth muscle. Sodium nitroprusside, we said sensitive to light, and then an unknown mechanism in the hydralazine. Now, our last category is going to be the RAS system inhibition. I'm not going to talk about it, but you can check the video about it if you haven't already. It is the exact same thing that you can mention here. So I hope this video was useful for you guys. I think like it would be good if you could memorize all of it. And see you in the next.